this event from PureView Live, taking the targeted option for myelofibrosis, insights on modern JAK inhibitor platforms and emerging therapies. I'm joined here tonight with two wonderful friends and world-renowned MPN experts, both Dr. Katrina Jamieson, a professor at UC San Diego, and my good friend John Mascarenhas, a professor at Mount Sinai School of Medicine. Thank you to PureView for providing this session, and to AbbVie, CTI Biopharma, and GSK for providing the educational grants for the symposium. Please, we're going to have some polling during the presentations, so certainly try to answer those as best you can. Also, we're going to try to leave some time at the end so you can submit your questions. We'll try to answer them during the Q&A session. You can visit the folks at PureView on this website here, both for MF content, and I know they have a whole range of interesting updated data going on both in heme malignancies and others in concert with these spring meetings. So our focus tonight is myelofibrosis. And again, this is a disease that both can originate in the primary state or evolving from ET or P. vera. In earlier disease, of course, we have a variety of difficulties patients can face: high counts, certain sets of symptoms, risk of thrombosis. But progression to overt myelofibrosis can come with cytopenias, increasing fibrosis in the bone marrow, as you can see, whether they're stained with reticulin or trichome, leukoerythroblastosis, splenomegaly symptoms, and the potential of transformation to acute leukemia. And all of this occurs in the set of an evolving understanding of both driver mutations as well as additional somatic mutations. Now, the diagnostic workup for myelofibrosis, in addition to your core exam, CBC, blood counts, LDH, etc., includes certainly excluding CML. There certainly can be a lot of mimicry, so certainly be certain to exclude BCR-ABL. A bone marrow aspirate and biopsy is really considered universally necessary for diagnosing this entity. Cytogenetics, if you can obtain them, certainly JAK2 and driver mutation status, additional NGS panels. Certainly be sure to capture their symptoms, not only just asking questions, but really use the tools out there, the MPN 10 symptoms that really help to quantify that baseline symptomatology. Get a sense of medications, the need for transfusions. Obviously, if they're younger, higher risk, we may be thinking about HLA typing in terms of possible stem cell transplantation in the future, etc. Now, this is a disease that we manage largely both based on the concept of risk as well as disease burden. With risk, there are innumerable different prognostic scores that are out there. Our current guidelines recognize that in terms of guiding therapy, we can use these scores, but largely we triage patients to lower risk or higher risk, with higher risk being a greater consideration of transplantation and lower risk either observation or medical therapy. Now, with these prognostic models, I'll highlight two of them. There are more, but I think that these are useful for the majority of individuals. On the right side, you have the DIPSS plus, which looks at both symptoms, blood counts, and karyotype to come up with a prognostic value. Over time, as we are able to obtain additional genetic testing, the MIPSS 70 is very helpful, both recognizing the negative prognostic implications of mutations such as ASXL1, IDH1 and 2, EZH2. These all can really have an additional biological negative, in addition to building on those other clinical features, even severe fibrosis that can be prognostic for these patients. Now, our guidelines, and Kat and I were the original inaugural panel chair and vice chair for the NCCN guidelines. We largely triage individuals to lower risk or higher risk. And in lower risk individuals, truly, if you were asymptomatic, both by the symptom score as well as asking the patient, perhaps we were best off observing patients. That may change over time. Now, symptomatic patients we think might benefit from therapy with either JAK inhibition, depending upon their difficulty, or if they have other problematic features, perhaps early use of pegylated interferon. Higher risk individuals, which is the vast majority, we would typically triage patients. If they were high risk, possibly a good stem cell transplant candidate, we might move toward transplant, perhaps with a run-in with a JAK inhibitor. Non-transplant candidates, we really distinguish based on baseline platelet count. Should we consider Ruxolitinib or Fedratinib as frontline options? Or if they were markedly thrombocytopenic, pacritinib as a frontline option. With any of these therapies potentially being second line, if the frontline options were not efficacious. All of this we need to monitor for signs, symptoms of disease progression and response. Now, with the JAK inhibitors, we have Ruxolitinib approved in intermediate and high risk, Fedratinib approved broadly against intermediate and high risk, both in frontline and second line. Pacritinib with a narrower but specific indication for those with marked thrombocytopenia, and we'll get into those data in just a little bit. Other therapies in development you'll be hearing about this evening include momelotinib for individuals with anemia, both a JAK2 and ACVR1 inhibitor. And you'll be hearing from Dr. Jamieson a little later, different novel mechanisms of action, everything from BET inhibition to BCL-XL. Now, transplant can cure myelofibrosis. However, it comes with significant risk and upfront risk. So with it, it's a complex discussion that we have with patients, that the higher the risk, the younger you are, the better you are a candidate, the more attractive an option it is. It's complex because it is a trade-off in terms of risk and potential long-term survival. And anyone who says that it's an easy decision is not someone that's had to face the decision for they themselves. As we think about therapy, again, we have challenges with the use of Ruxolitinib in the long term. Some individuals will certainly come off for a range of reasons, and reasons for ending can include anything from need to switch to a different medication, need for moving to transplantation, resistance, intolerance, or ability to participate in a clinical trial. So our goals for today are really for you to have a better sense, both the new therapies that have been approved or are in use, but also why the clinical need for these therapies as they were developed, as well as where our therapy is going to be going in the near future. So let's get into our first section with my colleague, John Mascarenhas, the modern customized use of JAK inhibitors. How do we elevate care? John, leader of the Myeloproliferative Disorders program there at Tisch Cancer Institute, along with our wonderful colleague, Ron Hoffman. Why don't you take us through upfront choices in MF?
All right, Ruben, thanks for the introduction. I'm really excited to be here with you and Kat today. And we'll get right into it with our first tumor board case. This is Patrick. He's a 60-year-old gentleman with a confirmed diagnosis of myelofibrosis. He presents with a spleen that's 16 centimeters below the costal margin. It's a very big spleen. He has bone pains that are diffuse, pretty bad at night, interrupts his sleep, night sweats, overwhelming fatigue, and has lost significant weight over the last 6 months. His platelet count is less than 50,000 routinely. His hemoglobin is 9.5, white count is 24,000, 2% blast. And on NGS testing, he's noted to harbor both JAK2, TET2, as well as the high molecular risk marker ASXL1. And he is not yet ready for a transplant, I think, both psychologically, and a donor has not yet been made available for him. So really the questions that we have that we're going to think about as we go through this next section is, what do? Do you just simply wait for the donor? Do you treat immediately? And if you do treat, what do you treat with? So that's really the thoughts as we move into the didactic part of this section. So here again, I'm showing the NCCN guidelines that are adapted for the high-risk patient profile, pointing out in the red box the fact that there is a decision node when platelets are less than 50,000 for either pacritinib or clinical trial if available. I will say that most clinical trials do exclude patients who have low platelets, but there are some trials that are out there, and this is really an unmet need. So treating patients with low platelets is both challenging, and low platelets themselves are clearly a independent prognostic marker for poor outcome. So our option pacritinib is based off of two phase 3 studies. Here I'm showing you the pivotal PERSIST-2 study. This was patients who had intermediate or high-risk myelofibrosis and who had, by definition, a cytopenic myelofibrosis phenotype, so platelet count less than 100,000. They could have seen a JAK inhibitor previously, and almost half of them did, and they were randomized in a 1-to-1 fashion to pacritinib 400 milligrams once daily, 200 milligrams twice daily, that's now the approved dose, or best available therapy, which could also include a JAK inhibitor. And once again, about half the patients ended up receiving JAK inhibition, namely low-dose pacritinib. The co-primary endpoint at 24 weeks was spleen volume reduction of 35% or greater, and a total symptom improvement of 50% or greater. And what did we see? Very strikingly and very obviously, pacritinib was superior to best available therapy at 24 weeks in terms of spleen volume response, 22% versus 3%, as well as symptom burden improvement, 35% versus 14%. And specifically, if you look at patients with platelet counts less than 50,000, and why specifically here? Because that's really was the unmet need. Ruxolitinib and fedratinib, both excellent drugs, have a platelet threshold of 50,000 or greater. So really, patients who presented prior to March of 2022 really had limited options, no approved option, and nothing that really could address effectively their spleen and symptom burden. And here, we look at the patients who had 50,000 or less platelets in the PERSIST-2, 29% versus 3%, SPR 35%, and 26% versus 9%, PSS 50%. So really quite active in this vulnerable patient population. And even if you look at patient global impression of change, which I really like, in terms of how do patients generally feel, they felt a lot better, the majority of the patients on pacritinib compared to best available therapy. Now, importantly, and sort of unexpectedly, or maybe not even initially really appreciated, was there was an anemia improvement that was seen with pacritinib as shown here. So the 200 milligram twice daily, the clinical improvement in anemia, which means a 2 gram per deciliter increase in hemoglobin or conversion from transfusion dependence to independence achieved in 25% versus 12%. But even if you look down the line, reduction in transfusion burden in the middle, and then if you look at units per month, a reduction from baseline from 1.06 units per month in blue with pacritinib to 0.67 at week 24. So there was a definite improvement in the anemia aspect of the disease. And we now know that this is probably due to multiple mechanisms of action with pacritinib, including the fact that it is uniquely an IRAK1 inhibitor, which works upstream from NF-kappa B and inflammatory cytokine signaling, but also because it is a potent ACVR1 inhibitor, which mediates hepcidin expression and iron availability for erythropoiesis. So what about toxicity here? I'm showing you the adverse event profile with PAC 200 milligram twice daily versus best available therapy. This is a FLT3 inhibitor. As with all drugs in this class, there is some degree of GI toxicity. It's mostly low grade. It's mostly in the first 1 to 2 months, very easy to counteract with an antiemetic or antidiarrheal, rarely a reason for discontinuation. So as long as you prep a patient for the potential for GI toxicity, very easy non-hematologic adverse event overcome. Otherwise, really wasn't a significant toxicity profile. This drug was put on a full clinical hold for a brief period of time in 2017 due to concerns by the FDA of increased cardiovascular and bleeding risk, leading to mortality risk with pacritinib. When the data was reviewed in its entirety, it was clear that there really wasn't an increased cardiac toxicity risk with pacritinib, perhaps at least in the PERSIST-2, an increased bleeding risk, which might be independent of the depth of thrombocytopenia. And generally speaking, we try to avoid patients who have a clear bleeding diathesis, who are on anticoagulation, or have an undiagnosed coagulopathy. So there are certain patient populations you might need to be careful, but this is easy to avoid in the majority of patients with thrombocytopenia that are in need of JAK inhibition. It's important to note that other studies, like the study presented and published by Moshe Talpaz and colleagues, looked at exploring lower doses of Ruxolitinib or Jakafi in patients with platelet counts between 50 and 100,000. Importantly, the COMFORT studies were designed for a baseline platelet count of 100,000 or greater, so additional information was needed in order to provide confidence to the practitioner that Ruxolitinib could be dosed in patients with 50 to 100,000. And in this strategy, the investigators started at low doses, like 5 milligrams twice daily, and titrated up to a target goal of 10 milligrams twice daily. As you can see by the waterfall plots that I have listed here, you really attenuate and compromise the spleen and symptom burden response at doses less than 10 milligrams twice daily. So if you can't get to 10 milligrams twice daily, you're unlikely having a significant or meaningful impact on spleen and symptom burden with Ruxolitinib. And that's an important point to remember, particularly when you have patients where you can't get to 10 twice a day due to thrombocytopenia, and one is looking to achieve optimal JAK inhibition. Here's some practical guidance on delivering therapies with Ruxolitinib. This is by nomogram for dosing of Rux by platelet count. Between 50 and 100,000, you're looking at 5 milligrams twice daily as a starting dose, and then again, trying to titrate up over time, if tolerable, from an anemia and thrombocytopenia perspective, to at least 10 milligrams twice daily. And then always keeping an eye out for the potential for infectious complications, which may be slightly increased in the setting of Ruxolitinib as a JAK1/2 inhibitor, and the need for dose modification or dose holding. What about fedratinib? Also a very effective and active selective JAK2 inhibitor, 400 milligrams once daily, with or without food. Personally, I think it's better with food. I think patients do better with fedratinib with food. Also very easy to tolerate in terms of a GI perspective. Anti-emetic, anti-diarrheal, usually within the first 1 to 2 months, rarely reason for discontinuation. If you do not prep the patient, they will be surprised and they will think the drug failed them. You have to keep that in mind. But a very effective JAK inhibitor, even in the second line in terms of salvaging spleen and symptom response. So keep an eye on that. And of course, it does have a black box warning. The only one of the JAK inhibitors we're talking about today for Wernicke's encephalopathy. So that's vitamin B1 deficiency. So please check a vitamin B1 level at baseline and every 3 months, or make your life easier and put the patient on B complex. Very easy to deal with. And again, not a reason to shy away from an active JAK inhibitor. And then with pacritinib, it's 200 milligrams twice daily. You do not need to dose reduce at initiation for platelet count. It's the same dose no matter what the patient's platelet count is. As I said, be careful of bleeding. One might consider holding the drug in perioperatively, and then make sure the patients have access to an antiemetic and antidiarrheal, particularly in those first couple of months. And then watch the counts. I treat through the thrombocytopenia because often the counts will even out over time. And as we pointed out, there are patients who can achieve significant anemia responses, but that sometimes is delayed. And then, of course, watch the QTc prolongation. I watch it with any of these drugs, but with pacritinib included. And there are parameters for holding it as listed here. So let's get back to our case. So Patrick, 60, big spleen, significant symptom burden, low platelets, and he has some high molecular risk markers. So I'm gonna open these questions up to my colleagues today now on our panel. I think the first question is, what do? Do you wait for a donor or do you treat this patient? Ruben, you're our moderator. Maybe you can start. What would you do in this case?
Well, I like to think of these situations as not, either or, but kind of and, so one, I think we need to acknowledge that, there's good sense from our field that most patients, if they need to go to transplant, probably are best off getting on a JAK inhibitor right away as you're starting that process. Almost nobody goes to transplant without at least a several week delay for approvals, testing, pre-transplant testing of siblings, etc. So this is an individual, 60, they got a big spleen, they have lots of symptoms, they're markedly thrombocytopenic, they've got high risk features. So I certainly would, transplant them when we can get there. But as it says, we don't yet have a donor. So I think I would start, and in this setting with a marked thrombocytopenia, I think pacritinib would be indicated. It's perfectly appropriate in the frontline setting for an individual with marked thrombocytopenia. Kat, what do you think?
Yeah, I agree, Ruben. And when you had the prescient notion that we should start the NCCN panel back in 2016, we really were grappling with just one inhibitor, Ruxolitinib, which is very good, but really is suboptimal in platelet counts, less than 50 patients. So I think that pacritinib makes the most sense here, provided that somebody doesn't have a bleeding diathesis, does not have QT prolongation. It's actually a very well-tolerated drug. So usually we look for those adverse events before they happen. We try and predict and prevent. And, you know, a lot of patients don't want to consider a hematopoietic cell transplant up front. They really want to try something else. We know that HCT works better anyway if you reduce the disease burden. So I think pacritinib's a choice. You know, if somebody's already on ruxolitinib, it may be worth altering the dose and seeing if you could get back up. Here, fedratinib could also be an option if for whatever reason they have a coagulopathy or QT prolongation. So I usually stratify by the patient's own risk of having an adverse outcome based on their comorbidities. But pacritinib looks like the best choice here.
Excellent. Thank you both. So our patient does go on pacritinib, and while the donor search is ongoing, and then the data does support it, as we talked about. And this patient really enjoys a significant improvement in spleen, symptom burden, stabilization of the platelets, and even an improvement in hemoglobin. So I'm going to now pass the baton back over to Ruben for the next tumor board part.
Wonderful. Well, great way to get us kicked off, John. So now we're going to focus on pretreated myelofibrosis and patients with anemia. And this is very relevant because, again, in the US, we estimate, other than patients that are newly diagnosed, most patients with MF are on therapy based on the benefits that we've had. You know, many of those patients do have anemia. So here's an individual. He's 75. He's been on Rux 10 BID for a little over a year. His spleen is at 4 centimeters, so he's probably had some reduction with that from baseline, so likely he's had benefit. He does not have significant abdominal symptoms, modest systemic symptoms, fatigue, etc. We do find that he's quite anemic, probably needs a transfusion. His hemoglobin 6.5, white count is 14, platelets of 82, 2% blasts. You know, do we continue therapy as it is? Do we reduce the Rux dose? Do we add in another therapy? Do we switch to another JAK inhibitor? If so, which one? We'll get back to some of these questions after I share some information with you. So currently, as we think about our guidelines, we showed you in the earlier part when I gave you the introduction, you know, guidelines as it relates to lower risk and higher risk. Now, when we created the NCCN guidelines, we had a special call out specifically for individuals with anemia for a range of reasons. One, we've not had an approved drug that really improved anemia for MF. And two, there are some other therapies that can be helpful. So with patients with higher risk MF or on therapy with a JAK inhibitor, again, we're giving those individuals, you know, we can consider a clinical trial, things of this nature, but we've not had kind of good alternatives for anemia. Now, in terms of managing anemia, one, if they're on a JAK inhibitor, we historically have kind of pressed on through, kind of despite the anemia. There have been patients I've had who were transfusion dependent, and the only option we had available at the time was ruxolitinib, and we kept them on ruxolitinib because the data would fairly clearly show that they're probably better off being on ruxolitinib with anemia than not being on anything at all. So certainly there's a benefit to being on JAK inhibition, but how can we optimize it further? Now, in terms of trying to improve anemia, we, one, considered supportive options, erythropoietin being one of them, or parallel erythropoietin stimulating agents, with if the EPO level is under 500 to consider an ESA. I'll share with you that I think the greatest likelihood of response really is if that level is under 100. They have baseline renal insufficiency, but at least it can be considered if under 500. I think the key when using EPO is that don't be afraid to stop it if it is not working. I think the negative is that there's people that get EPO, they have zero response, and they're still getting it like 3 years later. You know, please, you know, if they don't really have a benefit after 3 months, you know, and you feel that you've gone up sufficiently on the dose, just stop it. You know, it clearly does not work in everyone. Additionally, danazol can have some activity, and that's been further validated even as a control arm in the Momentum study. It has activity. Next, the IMiDs. And then luspatercept has been used off-label, but is clearly trying to seek an on-label approval. Now, as we think about second-line therapy, fedratinib is a good approved therapy that can be helpful in the second line that frequently, I think, is underutilized in the United States and needs to be considered more. The JAKarta-2 was a study that Dr. Harrison and I led that showed a response rate of roughly about 1 in 3 patients having a benefit for spleen and symptoms and those that had failed ruxolitinib. I think it's particularly good if they don't fall in the category of having pacritinib indicated with marked thrombocytopenia. So if you have patients that fit in that category, you don't have a clinical trial, certainly consider fedratinib. Momelotinib is an agent that may well become commercially available soon, and I'll show you the reason why that is the case. It's a JAK1 and JAK2 inhibitor, as well as an ACVR1 inhibitor. From its early days of testing, we identified that in addition to improving spleen and symptoms, it could help to improve anemia. There were further studies done with Stephen O. and others that seemed to suggest that the mechanism for the improvement in anemia may be a decrease in the inflammation associated with the disease, and that a decrease in hepcidin, which causes an anemia of chronic disease type state, could be decreased. I presented actually at last year's ASCO as an oral abstract, now published in The Lancet, the Momentum study, led by Dr. Rostovchik and myself, many colleagues. This was momelotinib versus danazol in the second-line setting, symptomatic, failed JAK inhibition, and anemic, then with an open-label crossover with improvements in symptoms, spleen, and transfusion independence as endpoints. What we identified was, one, there was very significant improvement in symptoms compared to danazol as the active control arm, and the two, updated information which Aaron Gertz shared at ASH, that those benefits were also durable. Second, we see here improvements really through week 48. And again, really not that benefit as it relates to the danazol arm. Patients that then crossed over then did have a benefit when switched to momelotinib from danazol. So all of these things further really validating the quality of the responses. As we look at improvement in anemia, again, we saw both improvement, non-inferiority, which was the planned goal from the beginning, really a lean toward superiority. And you see here both transfusion-independent duration of response, momelotinib versus danazol. And then you also see durability of that benefit, as well as change as it relates to crossover. So again, all of it showing very significant benefit in anemia, stable benefit in anemia. We also saw the core, and this was vastly superior to danazol, improvement in spleen. So momelotinib, is it a spleen drug? Is it an anemia drug? Is it a symptom drug? I like to think that it's a myelofibrosis drug, and that it is treating the disease, and then the manifestations of that benefit are splenomegaly, symptoms, and anemia. Indeed, I think that is an important concept with all of the JAK inhibitors. These agents are not targeted spleen or symptom agents. We measure spleen or symptoms because they're a helpful measure of clinical benefit. They're manifestations of the disease. I think there's probably further benefits that are recurring within the bone marrow milieu and other things that are beneficial to patients. There's been suggestion with most of these drugs, including momelotinib, that there may be a survival benefit. But I think that's an important point to distinguish them from the other drugs that I had mentioned that truly are anemia drugs. If I use an ESA, I'm hoping that it improves anemia. If I use a drug like momelotinib, I hope that it's really improving the natural history of that patient's myelofibrosis. Now, further evidence of impact on transfusion requirement. You see here that before and after the decrease in the number of transfusions, you see almost all the patients had some improvement or stability of transfusion intensity on the momelotinib therapy, and we'll have further updates on these data at the EHA. Now, practical considerations, it's dosed at 200 milligrams a day. Now, although I know there has been a culture of us adjusting the dose of ruxolitinib in patients because of anemia starting off at lower dose, if this drug becomes approved in the near future, please start individuals at 200 milligrams a day. And I've seen this phenomenon as the other JAK inhibitors have rolled out, that people are starting people on lower doses than recommended because of the history that we had with ruxolitinib. One of the values of a medicine like momelotinib is that, again, it can be given at full dose. Indeed, that's a parallel benefit to pacritinib that you had seen John present. Again, that these agents included, there's even data between it is a 50 to 100 with fedratinib, that it can be given at full dose. I think there is a dose response benefit in JAK inhibition that is relevant as it relates to the overall benefit. Now, in terms of toxicities, again, non-hematologic toxicities were not common. Small numbers of renal insufficiency or pneumonia. There are cytopenias, although of course it's difficult to separate, what's disease, what's drug, but one still needs to monitor the blood counts closely. So this individual, we go back to this individual. Let me ask John first. What might be your course of action for this individual? Would you have them remain on ruxolitinib? Would you reduce the Rux dose, add danazol? Would you switch to a different JAK inhibitor? If momelotinib were available, would you consider that, or pacritinib?
Yeah, I mean, so I think there's a number of different options and considerations. I think going down on the dose of ruxolitinib sort of misses the point. Once you start reducing the dose of your JAK inhibitor, you're actually moving away from the needed activity of that drug. You're lessening the JAK inhibition, which is probably overall not beneficial for the patient. So in this case, I don't think I'd reduce the dose of ruxolitinib, but I would look elsewhere to maybe swap out ruxolitinib for momelotinib as you presented, to sort of try to achieve that trifecta of spleen, symptom, and anemia benefit. One could also consider pacritinib could be another option here too, particularly since the NCCN does endorse it as a second-line option, irrespective of the platelet count. So that is the way I would go. Although one could, if momelotinib was not available and or pacritinib was not accessible, one could add danazol. You and I did a phase 2 study some years ago looking at the ability to add danazol to ruxolitinib to salvage anemia responses with a modest effect. But if you're really trying to get the full benefit of therapy, you'd want to go in with an active JAK inhibitor and hopefully one that could improve anemia. So I guess here it really would be momelotinib as a consideration.
Wonderful. Kat, what do you think?
Well, I would see what's available that is FDA approved first, unless the patient says they want to be on a clinical trial, and momelotinib is still not FDA approved, although we're certainly excited about it, the data that you presented, Ruben, and it looks very promising. So I would go with an FDA approved drug in this setting, provided that the patient says they want to just have an FDA approved drug. Probably do a bone marrow biopsy as well as look for any evidence of GI bleeding if somebody's really profoundly anemic. Just because somebody has myelofibrosis doesn't mean they can't have colon cancer or some other reason to be anemic. So I usually do that workup, and because of the 2% blast and the age, I want to make sure that they're not progressing substantially. But for other JAK inhibitors, what's NCCN approved by guidelines is fedratinib as category 1A, and then category 2B is pacritinib, because it was really approved in the less than 50 platelet setting. Again, I stratify according to what patients want. If they say, you know what, I have had a history of arrhythmias and I'm worried about QT prolongation, then pacritinib may not be the best choice. If momelotinib gets approved, yes, that would be lovely. We'd love to give that drug frontline for people that present like this with anemia as their main symptom. If fedratinib is a consideration because we feel their disease isn't really getting handled, they're not getting enough JAK2 inhibition, then that would be the choice. And again, that's where I would think this is a time to potentially do another bone marrow biopsy. And even though when we look at the MIPS, the Mutation Enhanced International Prognostic Scoring System 70, it's really meant to stratify for hematopoietic cell transplant or not based on mutations. It's actually quite useful in everyone. So I think we're starting to use that more for next generation sequencing as a risk stratifier for patients so they can make these choices. And I just say these are the side effects, just like we have in chronic myeloid leukemia. You've got dasatinib. Well, if you get short of breath easily, it might not be the best drug. Nilotinib, if you get arrhythmias, may not be the best drug. So clearly, if momelotinib is approved, that would be the one. But before that is, I would go with an FDA-approved drug, either fedratinib, and if that's not available, pacritinib.
Wonderful. Well, I hope folks are getting a sense that there's a range of options now. It's more nuanced than it was before. I think there's sometimes a little reluctance to jump to one of the newer agents, but I would heavily encourage you to consider them. The other point that Kat brought up is really a good one. Someone that sees a lot of these patients as referrals or second opinions, isolated anemia, I certainly have seen a range of concerning other causes for that. Everything from GYN malignancies, endometrial cancers, certainly colon cancer. So certainly always wear your hat as a hematologist, to be sure. It certainly can be progressive MF. Don't know, no question about that, but be pretty certain. So again, this individual, again, clearly I think it needs intervention. I think clearly always transfusing, no matter what you start, none of that is going to kick in right away. So certainly if a patient needs a transfusion, give them a transfusion. Other options, luspatercept is trying to get an approval, certainly can be given off-label. I would probably encourage some of the other things first, but certainly it can be a consideration or, of course, a trial. Now, on the virtual platform, as we continue the presentation, please take a moment to answer the follow polling on the making treatment choices using JAK inhibitors in MF. That'll go on in kind of the right hand of your screen as we continue on with the presentations. So for our final segment, before we take Q&A, and please be sure to be entering your questions, let me hand it over to Kat, who will be taking it through novel mechanisms of action.
Thank you so much, Ruben and John, for setting the bar very high. Anyway, so here's our third tumor board question: worsening disease despite previously effective therapy with a JAK inhibitor. And as Ruben and John were mentioning, there are many choices now. So we know that you really want to refer your patient to a hematologist who actually sees a lot of patients with this disorder that affects 1 per 100,000 people in this country. So we've got Allison, 70-year-old woman with myelofibrosis. She's been on ruxolitinib 20 milligrams twice a day for over 2 years, but despite responding well initially, she now presents with an enlarging spleen, pretty large actually, 16 centimeters below the left costal margin, with abdominal symptoms, and then also night sweats and fatigue, which are very common as people find their disease is progressing with loss of response to ruxolitinib. And remember, only about 25% of people are on ruxolitinib after 5 years, in part because of progression. So other findings include a hemoglobin of 9.5, white blood cell count of 14, and a platelet count of 98. So what is the best course of action? Should they continue on ruxolitinib? Should they increase the dose? Should they switch to a different JAK inhibitor, or consider a clinical trial with add-on therapy that has a different mechanism of action? And that's really where the field has gone over the last few years. So we'll come back to that case in just a few minutes. So in terms of canonical and non-canonical actions of JAK2 and opportunities for therapeutic targeting, what a lot of us in the field have started to realize is that the disease progresses when you're really dealing with monotherapy. And so patients have appropriately demanded that we consider alternative mechanisms of action. And that's not to say that JAK2 inhibition isn't important. It's just what should we add to that to make it sustainably effective? And Ruben brought up this very important point: durability of response. Patients want to have durable responses and not have to be switching to something else in a couple of years. So when you look at what the JAK2 signaling pathway does, it can actually activate downstream signaling pathways that promote survival, in part through STAT3 and STAT5 activation of pro-survival proteins, BCL-XL and BCL2. And we've been in a very good position recently because of lessons learned from acute myeloid leukemia that BCL2 inhibition can be life-saving. The only thing is it's a little bit more complicated in myelofibrosis. In most patients with myelofibrosis, they've activated not just BCL2, but other BCL2 family members like BCL-XL, and that promotes survival of the malignant clone. So now there's a very active drug called Navitoclax, which I'll talk about, and that has really had really remarkable responses. The other opportunity here is that we have what's called a BET inhibitor, bromodomain and N-terminal inhibitor, that works inside the nucleus. It's a really important opportunity to really change the epigenome, and that's called pelabresib. And that is something that, again, in combination with ruxolitinib, is looking very interesting. And what's not on this slide is telomerase reverse transcriptase. As these cells start to transition from pre-malignant stem cells to fully malignant leukemia stem cells, they activate a gene called telomerase reverse transcriptase. And while that's supposed to keep our stem cells living longer, unfortunately, in myeloproliferative neoplasms, that happens in the malignant clone, as shown so nicely by John Mascarenhas. And unfortunately, that perpetuates the longevity of the wrong cells. So I'll talk about those three opportunities in the context of combined therapies. So for the pro-survival BCL2 proteins, including BCL-XL, they tend to be overexpressed in the MPN setting as patients progress from lower risk to intermediate and high risk disease. Now, we know that ruxolitinib is very effective at inhibiting JAK2, but often in patients, as I mentioned, it's not enough, because STAT3 and 5 signaling can activate BCL-XL and also MCL1. We're still looking for an MCL1 inhibitor, by the way, but Navitoclax is very effective at blocking that BCL-XL pro-survival protein and also BCL2. So it's a twofer. It works actually very well. So the addition of Navitoclax to ruxolitinib in patients with suboptimal responses to ruxolitinib monotherapy has actually demonstrated preliminary efficacy, safety, and evidence of disease modification, which is what we're all looking for now. So this is the phase 2 REFINE trial data, where we used add-on therapy with Navitoclax in patients with myelofibrosis and a suboptimal response to ruxolitinib. There were 34 patients with intermediate and high-risk myelofibrosis who had evidence of progression or at least a suboptimal response on stable dosing with ruxolitinib of at least 10 milligrams twice daily. Patients received Navitoclax at 50 milligrams once daily, followed by escalation to a maximum of 300 milligrams once daily in once weekly increments. And what we saw was a spleen volume reduction of 35% was achieved by 26.5% of patients at week 24 and by 41% of patients at any time on study, with an estimated median duration of response of SVR35 of 13.8 months. So that's what Ruben was alluding to, that durability of response. So with patients who achieved the SVR35 and total symptom score 50 at week 24 and bone marrow fibrosis grade improvement at any time on the study, you see that they tended to do quite well. So there's the nice thing about this study, it actually took into account the grade of bone marrow fibrosis, which we're really using, as Dr. Mesa mentioned, as a key prognosticator in disease now. We're also looking at durability of response. So when you look at the REFINE study, the total symptom score and bone marrow fibrosis improvements Those were noted with the addition of Navitoclax to Ruxolitinib. A greater than 50% reduction in total symptom score was achieved in 41% of patients. And really, in a very positive way, bone marrow fibrosis improved by 1 to 2 grades in a third of evaluable patients. So that's a game changer. Reversible thrombocytopenia without clinically significant bleeding was also seen, and actually was the most common adverse event. And I should say it was manageable with dose reductions and interruptions, but also it tended to last a little bit longer than we'd originally anticipated and could go out for as much as a month. So it's something to keep in the back of your mind. Navitoclax will block BCL-XL in the progenitors that give rise to platelets. So the effect lasts a little bit longer than the 7 days you'd expect to just make more platelets from megakaryocytes. In terms of our role for combination therapy in JAK inhibitor naive myelofibrosis, cohort 3 of the refined study enrolled JAK inhibitor naive patients with myelofibrosis. They received Navitoclax 200 milligrams as a starting dose plus Ruxolitinib. And you see that this tended to work quite well in patients who have poor risk or poor prognostic findings. 1/3 of patients who achieved SVR 35, meaning a spleen volume reduction of 35%, also had a reduction in bone marrow fibrosis. Again, that may impact the durability of response. So when you look at novel mechanisms of action in treatment refractory disease, we're really going after durability of response. I'm going to really hammer that point home. This is work done by Dr. Mascarenhas, who's here on the call. And really, again, going after where can we think about treating patients who have shown a suboptimal or inadequate response to JAK inhibitors. Is there another mechanism of action we can target? And this is an example of targeting telomerase reverse transcriptase, TERT for short. Elizabeth Blackburn discovered it and found it was a double-edged sword. She got the Nobel Prize for showing it's important for stem cell longevity, but when activated too much can lead to cancer progression. So in this EMBARK study that was led by Geron, and in this case, Dr. Mascarenhas as the lead PI, patients were randomized to imetelstat 9.4 milligrams per kilogram or 4.7 milligrams per kilogram IV once every 3 weeks. And at 24 weeks, spleen and symptom response rates were 10.2% and 32% respectively in the 9.4 milligram per kilogram arm. Treatment with imetelstat 9.4 milligram per kilogram led to an overall survival of almost 30 months. Again, back to sustainability of response. So that was quite dramatic. And this coincided with bone marrow fibrosis improvement in 40% of patients. So again, it looks like if you can reduce bone marrow fibrosis, you may have an enhanced sustainability of response in these higher risk patients, relapse refractory myelofibrosis. Now, this takes us to overall survival. When you look at biomarkers and bone marrow fibrosis assessments, it suggested a selective effect on the malignant clone, with patients who had bone marrow fibrosis improvement actually having a greater overall survival. So again, John Mascarenhas demonstrated that. This had been alluded to in 2 previous New England Journal papers in very early phase clinical studies, but this was the most robust clinical study to show the overall survival change. Now, what about novel mechanisms of action beyond the drug we just talked about, imetelstat, BET inhibitor? BET inhibitor pelabresib, combined with ruxolitinib, is active in therapy-naive myelofibrosis. So pelabresib and ruxolitinib showed clinically meaningful improvements in splenomegaly and symptoms, as you see in these waterfall plots here. So morphosis has continued to develop this combination strategy. Biomarker findings indicated potential disease modification, and combination has generally had a favorable safety profile. So this takes us back to tumor board question number 3. You have Allison, our 70-year-old woman with myelofibrosis, who's been on ruxolitinib 20 milligrams twice a day for over 2 years, who, despite responding well initially, now presents with an enlarging spleen, pretty big at 16 centimeters below the left costal margin, with abdominal symptoms, night sweats, fatigue, and then the findings of anemia, slightly elevated white count, and mild thrombocytopenia. So I'll ask Ruben first, what would be your suggested course of action here?
Well, so he's 70. He's already been on kind of maximum dose. He has a big spleen, has symptoms. The blood counts are pretty good. So one, I'd say, we've maxed out the Rux, having an inadequate response clearly at maximum dose. At 98, I think, this is an individual, one, there's no benefit to further increasing the dose. There have been times I've gone above 20 twice a day in PV for pruritus, but certainly not in this setting. Certainly fedratinib, would be a real consideration for this individual. The platelets are above 50,000. There's good evidence from the JAKI study that probably, outside of a clinical trial would be my first choice. Certainly there's data from PERSIST-2 that pacritinib could be considered in this setting as well. Undoubtedly, a clinical trial with an add-on therapy certainly would be very appropriate as well. And obviously the decision to go on a clinical trial is a personal one, both based on access, distance that one has to travel, and other pieces. But certainly, again, I think Navitoclax, pelabresib, any of those clinical trials with add-on would be very reasonable. But I know these folks are out there and they don't all go on trials. So for those that aren't using fedratinib or pacritinib yet, I think certainly considered in these sort of circumstances. How about yourself, John?
I think I agree with you. I mean, I think the point to remember here, particularly for the clinicians in the audience, is that often when we think that patients aren't garnering benefit from ruxolitinib, we sometimes make that mistake of yanking the Rux and then figuring out that they still were actually enjoying some degree of benefit, and they can get this very robust cytokine rebound and feel pretty unwell. So I would probably opt to, and obviously I'm biased at a center where we try to do clinical trials. I probably would put this patient on a clinical trial with an add-on strategy, as Kat nicely laid out. Navitoclax would be a consideration, and it is in phase 3 testing for patients either upfront or patients in the second line that have lost that initial response. I think imetelstat would be another interesting consideration. It's not necessarily the drug I think of as a spleen and symptom benefiting drug, although it does have activity in that setting. It's more of a survival sort of endpoint drug, and now it's being combined with ruxolitinib based on some preclinical modeling by some colleagues at Mount Sinai. And then, I would also kind of consider the fact that 70 is not elderly. 70 is still a transplantable age. So I think in someone who's having progressive disease like this, I think transplant should still be considered. But I'm not sure I would send the patient right to transplanters. Transplanters typically don't like spleens at 16 centimeters. So I would still employ some intermediate medicinal approach, perhaps with an add-on strategy with an eye to transplant if Allison was so inclined.
Well, thanks so much. And transplant generally works better, as you were mentioning, John, when the spleen is a little bit smaller. And if we're really getting a reduction in bone marrow fibrosis, again, engraftment should be better as well. So that sums up the recommendations. It looks like we're all on the same page. Just to say that patients have options now. Continuing therapy unchanged is suboptimal. Increasing the current dose is unlikely to be beneficial, as Ruben, you mentioned. Switching to an alternative JAK inhibitor is a guideline recommended approach by the National Comprehensive Cancer Network, and those new guidelines are out now for this year. Clinical trial enrollment is a feasible option, including pursuit of add-on therapy or a different mechanism of action, as you mentioned, John, with imetelstat, again, on a clinical trial. But we're going to have an embarrassment of riches when it comes to therapeutic options. I think really the point is don't wait too long, because patients have these options and they really need to know about them. And that's where we'd like to guide the audience here when we go to the chat and answer some of these questions. Back to you, Ruben.
Wonderful. Well, some take homes before we have some questions, and some have come in the chat in the few moments that we have. First, MF is a heterogeneous disease. Clearly, you have to be thinking about disease risk, individual factors, as well as our options. We have 3 going on 4 JAK inhibitors. They clearly have benefit. They clearly both overlap in terms of areas of efficacy, but they do have some important distinguishing factors in terms of toxicities we manage or expectations of efficacy. Anemia is a challenging problem. There's limited approved options. And certainly we're hopeful that that 4th option with momelotinib may come to realization. So again, we will have more nuanced options for our patients. They're really thrombocytopenic, pacritinib. If they need good upfront JAK inhibition, there's both Rux and fedratinib. We have momelotinib, again, that may play a role with significantly anemic patients in either setting. So let's transition to some questions. So let me ask John, perhaps for this first one. When is it appropriate to use dose increase rather than change medication when it's experiencing a suboptimal response to ruxolitinib?
So I think, I think the decision to dose modify Rux depends on a lot of different aspects and variables. So I think if you're already at doses of greater than 10 milligrams twice daily and you're not achieving, maximum spleen and symptom benefit, although one could go up on the dose and sometimes that is a thought, there is a dose-dependent improvement in spleen, but unlikely symptom burden. So I think if you're already at doses of 15 or 20 milligrams twice daily of Rux, I think that is when I'd be looking for the second line option. And, in many cases, I think fedratinib would be a consideration, pacritinib would be a consideration, or of course, on a multiple choice question, clinical trial is always the right answer. So clinical trial consideration as an add-on strategy.
Wonderful. Maybe I'll take this second one and then to pass the third one to Kat. But when should a community hematologist oncologist refer an MF patient to an academic center hemonc? Well, I think really kind of twofold. One, I think, younger patients, higher risk, the issue of stem cell transplant, it clearly, I think having a transplanter on board for someone who potentially could receive a transplant in the future is helpful. So unless transplant is really